Indian Myeloma Academic Group, wherein this day marks the 25th Journal Club and Journal Scan that we have been hosting successfully in cooperation with Mice Ideas. Also, though it has been more than 28 months, but in between for 2 or 3 months, we couldn't hold the Journal Club because of either it clashing with the dates of Indian Myeloma Congress or with the International Myeloma Society annual conferences. But today happens to be the 25th Journal Club. So we thank each and everyone who has been part of this particular journey for making this event a successful event, not only within country, but also in the other SAARC countries and in the South African countries. Also, the second important thing happens to be today we have on board a few more physicians and clinicians from Southeast Asia, wherein we have requested a few people from Asian Myeloma Network and International Myeloma Foundation to be part of today's meeting. So I was confirmed that few of them are participating as the members today, as delegates or attendees. So I welcome them also on board, and we would look forward for future collaboration and cooperation from these countries to expand this particular event to the complete Asian Myeloma Network and to International Myeloma Foundation, to all those resource constrained countries wherein the academics or such activities are not a frequent occurrence. With this few words of introduction, I would like to hand over the proceedings of the meeting to Brigadier Das sir, who happens to be my ex-HOD at both Pune and Delhi. So over to you, sir, for taking forward for today's activity.
Thank you, Colonel Uday. Thank you very much. Good evening to everybody. General Nair sir is there and all the international and national faculty. Today, the topic they have chosen is Waldenstrom macroglobulinemia. You know, I remember days where we used to treat with chlorambucil, then CHOP, then R-CHOP, and then BR. Now it is BTK inhibitor, which is mostly oral or what you can say targeted therapy. I think today's topic is BTK inhibitor in Waldenstrom macroglobulinemia. This journal will be presented by Dr. Ramesh B. He is a consultant and head, Department of Hematology and Bone Marrow Transplant at Bhelamal Medical College Hospital, Madurai. This will be followed by discussion by Dr. Prantar Chakravarti. We all know him, our good friend. He is a consultant hematologist at Johor Corporation, Tenkasi, Tamil Nadu. He has been professor and head of hematology in Calcutta, NRS Medical College. So with this introduction, now I will request Dr. Ramesh B. to start his presentation on this journal.
Very good evening to one and all. Thank you, Das sir, for the kind introduction. So let me share my screen. So simplified risk stratification model for patients with Waldenstrom macroglobulinemia. This is published in Journal of Clinical Oncology recently. So coming to the background, Waldenstrom macroglobulinemia is an IgM secreting lymphoplasmacytic lymphoma. It has a heterogeneous course, like some patients may be markedly indolent while others can rapidly progress. The clinical manifestations are mostly due to either the symptoms due to cytopenias or due to hyperviscosity or amyloidosis related changes, or peripheral neuropathy due to amyloidosis, or cryoglobulinemia, or histological transformation to an aggressive lymphoma. So coming to the risk stratifications which have been used in Waldenstrom macroglobulinemia, first is the IPSS Waldenstrom. There are 5 categories, like age was one of the criteria, hemoglobin, platelet count, and beta 2 microglobulin, and IgM concentration. All these were the 5 categories. And the patients diagnosed and treated prior to 2002 were classified, were taken into account, and this risk stratification is made. It was before the frontline use of chemoimmunotherapy, a proteasome-based inhibitor, or BTK inhibitors. So revision in the IPSS scoring was published in 2019. Here they have removed hemoglobin, platelet, and IgM concentration. So only the age, beta 2 microglobulin were retained, and additionally LDH and serum albumin were added on. And there are 5 risk groups were classified: very low, low, intermediate, high, and very high. So why do we need a new modified risk scoring system for Waldenstrom macroglobulinemia? First, the IPSS did not assess the issue of non-Waldenstrom related deaths, and the revised IPSS did not examine the impact of the molecular parameters, which includes the MYD88 mutation. And the revised system also would only be partially replicated in the validation cohort. So this study was intended, and they have examined the performance of the revised IPSS in treatment naive patients with active Waldenstrom macroglobulinemia, and they have proposed a refined prognostic model with an external validation in a multi-institutional cohort from US and Europe. So research question is there a role for a new risk stratification system in patients with active or symptomatic Waldenstrom macroglobulinemia? So the methods, there was derivation cohort, which included the patients with active Waldenstrom, and the patients diagnosed between 1996 and 2017 were included. So the patients treated Mayo Clinic, Rochester were included. They applied our revised IPSS in patients with all the data available, with all the parameters, and the statistical analysis, univariate Cox proportional analysis was done using the clinical and laboratory parameters which affected the overall survival, with all-cause mortality as the event of interest in the MCR cohort. The multivariate Cox proportional regression analysis included the patients with only the complete data for the variables to identify as independent prognosticators for overall survival. The variables which deemed independently prognostic with the p-value of less than 0.1 on the multivariate analysis, they were assigned a score proportional to their hazard ratio, and those having the comparable hazard ratio were assigned equal points. So the validation cohort included 5 centers from US and UK. These are the 5 centers. The Kaplan-Meier method was utilized for the time to event analysis, and the survival was compared using the log rank test. And the competing risk analysis was used to validate the model on the basis of the cause of death. So the death occurring from Waldenstrom progression or histological transformation or amyloidosis or a Waldenstrom directed treatment associated complications, including the therapy-related myeloid neoplasm, were considered as Waldenstrom related, and the other death from other causes were labeled as competing events. The patients alive at the last follow-up were censored. The discriminatory power of different models and the relative goodness of fit for predictive score was assessed by computing the Harrell's concordance index. So coming to the results, so these are the patient characteristics. The total of 889 patients with active Waldenstrom at the MCR cohort. The median follow-up duration was 8.2 years, and the median age was 66 years. And this age-wise distribution, the predominant population falls in the 6th decade, followed by 7th and 5th decade. Predominant were male population, and the first degree relatives having the history of malignancy was present in 40% of the population, and the hematological malignancies were present in 9% of the population. The patient with amyloidosis were 8%, and histological transformation occurred in 4% of the population. Hyperviscosity is present in 13%, and the MDS transformation present in 2%, and Bing-Neal syndrome, that is CNS involvement, was present in 1.4%. The estimated median overall survival for the entire cohort is 10.6 years. The constitutional, this clinical features, the constitutional symptoms are present in 57%, and lymphadenopathy was present in just 20%, and splenomegaly in just 10%. And coming to the laboratory investigation, these are the median parameters, like median hemoglobin was 10, and platelet count median was normal. IgM median level was 3.7 gram per deciliter. Beta microglobulin median was 3.4. And the marrow plasmacytosis was present in 50% of the population. MYD88 mutation was present in 78% of the population. This is a univariate and multivariate analysis. In the univariate analysis, the age group, the 66 to 75 years versus less than 65, and more than 75 versus 65 were significant. And beta 2 microglobulin more than 3 microgram per deciliter was significant, and LDH more than the upper limit of normal was significant, and albumin less than 3.5 gram per deciliter was also significant. Coming to the multivariate, when we see the multivariate analysis, the beta 2 microglobulin was not significant, but whereas the other age, LDH, and albumin retained their significance. When you see the MYD88 mutation status and the overall survival, there was no difference based on the MYD88 mutation. So the prognostic model score calculation. So score 1 was assigned to serum albumin and age between 66 to 75 years, and score 2 for age more than 75 years and elevated serum LDH. So the prognostic model was generated with these scores. The composite score of 0, 1, 2, and 3 to 5 were clubbed together because there were only limited patients who had a score of 4 and 5. So only total of 4 risk groups were made. These are survival outcomes of the derivation cohort based on the MSS scoring. The 5-year overall survival is 93% for the low risk and 82% for low intermediate and 69% for intermediate and 55% for high risk. When we see the 10-year overall survival is 60% for low risk and 53% for low intermediate and 45% for intermediate and 30% for high risk. So when we see the patients who had histological transformation and amyloidosis, it was not significantly different across the across the 4 risk groups. So was there any selection bias because there was exclusion of patients with unavailable data in the MCR cohort? So this was also analyzed and published as a supplementary. So that with the data available and unavailable were compared, and that was not significant. And the individual parameters: serum albumin, beta microglobulin, serum IgM, serum LDH, hemoglobin, platelet, bone marrow lymphoplasmacytic cell infiltration, MOD88, and serum free radiation, none were found to be significant between those which were available and unavailable. So this is the time period of different the missing data had been mentioned in the supplementary. And coming to the prognostic model validation, the external validation was done. The total number of patients 335, median follow-up was 6.3 years. And the overall survival at 5 years was 93% in low, and low intermediate is 90. There was only marginal difference between low and low intermediate at 5 years. Whereas in intermediate and high, there was significantly different, like 75%, 57. When we see 10-year overall survival, that segregated further between the low and low intermediate. Low was 91% and low intermediate was 80%, and intermediate was 64% and high was 35%. Revised IPS when after the MCR intermediate group was properly. The intermediate risk group was not properly segregated from the very low and very high risk groups. So when this revised IPS is applied to the external cohort, again the intermediate and low were merging together. So when we see the distribution of patients between the revised IPSS and the MSS scoring, so there were major shuffling between the risk groups. So one interesting point which I which I could find here is like there the IPSS 11% of the population, the high risk group, they shifted to the low risk group. By just eliminating the beta-2 microglobulin. So coming to the cause of death in Waldenstrom, so it was approximately due to Waldenstrom related death was approximately between 54% to 70%. So coming to the treatment patterns, so the initial period before the 2000, mostly patients were treated with alkylator monotherapy. In the recent after 2010, the BTK inhibitors have started to use of BTK inhibitors has started to increase, and rituximab monotherapy was used in a predominant population, followed by rituximab alkylator combination. This is a distribution of treatment. Predominant was a single agent rituximab monotherapy, and rituximab combination, alkylator combination was used in 28% of the population. The performance of MSS risk group in the rituximab treated cohort was found to be statistically significant amongst the 4 risk groups. Similarly, the non-BTK inhibitor treated cohort were also significant amongst the 4 risk groups. Coming to the discussion, so low serum albumin, elevated LDH and age remained significant in the multivariate and low serum albumin, the marker of it's a marker of patient's overall health and poor nutritional status, and reflected the reduced hepatic synthesis, and it mediated in part by high levels of circulating interleukin 6. So elevated LDH is a marker of high cell turnover, aggressive disease biology. The age remained even in the patients more than 75 years, it remained significant. Whereas the hemoglobin, beta-2 microglobulin, IgM concentration were not prognostic in the cohort. So MSS prognostication system. So it provides a greater degree of heterogeneity with the few variables, and it was a 4-tiered segregation, unlike a 5-tiered segregation of the revised IPSS. So concordance index, which is a metric to evaluate the predictive models capacity to discriminate, was higher for the MSS than the IPSS model. And the MSS could capture the heterogeneity of the outcomes within the each stratum of IPSS Waldenstorm. Revised as a poor discrimination survival curves, especially in the intermediate group, which is similar to the original revised IPSS study. Unlike the revised IPSS Waldenstorm model, MSS reliably differentiates the high and intermediate risk cohorts from the low and intermediate. The survival curves of the low and low intermediate groups in the MSS, they were not at the end of 5 years, they were very closer, whereas we could see by the end of 10 years, they were able to segregate. So with the further time period, they could diverge further. So limitations of IPSS model was the lack of data regarding the cause of death and its impact. The revised IPSS, 22% were deemed as Waldenstorm unrelated, whereas in MSS, the 37% were deemed as Waldenstorm unrelated. So have they eliminated the lead time bias? Yes. One in 5 patients with active Waldenstorm had a antecedent smoldering Waldenstorm. So the estimation of OS was done only from the active or symptomatic Waldenstorm rather than from smoldering. So MOD88 mutation status had contrasting impact on the oral survival in the previous studies in the literature. Whereas in this derivation as well as validation cohort, the MOD88 genotype did not significantly influence the outcomes. Coming to the treatment regimens and outcomes, so because most of the patients, a large group of patients, they were used the rituximab-based therapies in the relapse remitting situation, it was difficult to comment on the specific therapy regimen and the survival outcome. But rituximab monotherapy or combination definitely has a better survival outcomes compared to the non-rituximab era. Because in the non-rituximab, prior to the rituximab era, there was inferior supportive care and limited access to the novel effective treatment. So limitation study is the retrospective study, and CXCR4 mutation and its impact on the resistance to treatment and the survival was not incorporated in the model. And moreover, it was challenging to incorporate the CXCR4 mutation because of the cost and the complexity in the testing. And owing to the shorter follow-up since the approval of the BTK inhibitor, only a small fraction of had received the BTK inhibitor. So the applicability of this prognostication system in the BTK era would require re-examination in the future with a larger cohort prospective study. So to conclude, the MSS, this is a simplified and external validated risk stratification model based on the patient's age, albumin, and LDH. With the limited variables, only 3 variables, this model has a better discriminability in the oral patients with Waldenstone. So this provide a platform for future refinement by incorporating other genetic and molecular data like deletion 6q, deletion 17p, other mutations like TERT, CA.
I think there were some communication problems. Now we have lost him. So we'll just wait for him to rejoin.
Yeah, I think Prantar, he's whether it got switched off because it immediately got cut off.
Yeah. There might be a power issue also.
We can start the discussion. I mean,
I think
because he was
Prantar, you
there
can
on the
start the
last
discussion.
slide. Yeah. So welcome, Dr. Prashant. Thanks for joining in. I think we can start the ball rolling. I do not see any questions in the chat box, but I think I would like to know from the horse's mouth as to what was the thinking beyond designing this, and what were the major learnings during this development and when you validated it.
Sure. So thank you for inviting me, and it's indeed my pleasure today to join and talk about the background, because it's, as you said, it's always important to know what went into designing such a study. So first of all, as we all know, the IPSS-WM has been utilized, although sparingly, for more than 2 decades now, or roughly about 2 decades now. And the challenges with that staging system are that primarily it was designed for patients in the pre-rituximab era, and there were some issues that were subsequently actually captured by other groups that showed that the LDH was a very valuable prognostic marker and was able to segregate those IPSS WM related cohorts further into high risk and low risk cohorts. So there was clearly, and that paper came out within a few years of the publication of the IPSS-WM. So there were clearly issues with that kind of a risk stratification. Moreover, it was a very complex or complicated system in the sense that it utilized 5 parameters. There were this IgM levels, for instance, just kicked in only if it was very high. The age had a different scoring system, and it was thrown out of stage 1 if it was low. And so there were issues that led to reduced practicality of the entire staging system. Obviously, there are calculators for it, so it's not that difficult. But overall, I think the problem was that with the novel agents, particularly BTK inhibitors introduction, the validity of this model was also questioned. Additionally, it was found that whatever the model was giving in terms of the overall survival of patients, particularly the high-risk patients, that was no longer applicable because of all the progress made in the field. So that led us to obviously reconsider the staging with our large data set. And number 2, our patients were followed for a very, very long time. As all of you know, this is a very indolent disease. And unless we have a long follow-up, we will not be able to do justice to any kind of analysis. And that is also evident in our model, frankly, because the BTK inhibitors, for instance, were only utilized in the frontline setting beyond 2015. So that's when they got approved. So Dr. Ramesh, great presentation. Sorry we lost you towards the end, but thank you for analyzing the paper, and you did great justice by going into the details. So we were just discussing how BTK inhibitors were just introduced. It got approved, the first BTK inhibitor, ibrutinib, got approved in 2015. And while all that data that was submitted to the FDA was related to relapsed refractory patients, surprisingly, the FDA omitted that clause of utilizing it or approving it for the relapsed refractory population alone. So it just said approved for patients with Waldenstrom macroglobulinemia, which essentially meant it could be used for the frontline or upfront setting as well. But there was another trial that was going at that time in the frontline setting. There was no reason for us to believe that something that worked in the relapsed refractory setting wouldn't work in the frontline setting. But it is also important to understand that there are certain regimens that work somewhat better because the risk in the relapse refractory setting, because the risk benefit profile changes. Specifically, to give an example, for Waldenstrom, there was this mTOR inhibitor, everolimus, that showed that it was able to rescue patients who were multiply relapsed and had refractory disease. But when that same drug was utilized in the frontline setting, there were some deaths noted. So the context obviously changed, and nobody would ever use everolimus in the frontline setting for Waldenstrom, precisely because of the toxicity associated. Fortunately, the toxicity with BTK inhibitors had substantially, in the relapse refractory setting, was substantially manageable, and the drugs were well tolerated. But the other important aspect with this paper was that we hadn't used BTK inhibitors in the frontline setting. And so the follow-up of patients with Waldenstrom that had received frontline BTK inhibitors was very short. And even in the relapse refractory setting, while there were many more patients, it would take a while for that data to mature. In between, in 2019, our IPSS model was introduced by the Greek group, predominantly led by Dr. Kastritis. And that model actually was not based on just looking at the overall survival prospectively. What they looked at was the parameters that they came up with in the multivariate analysis, looking at the 3-year mortality rate. So a priori, they had decided that they would create a model that would identify the patients that were at highest risk of dying from WM or non-WM, that was related more deaths, but and taking that into consideration, they looked at various parameters specifically for patients who died within the first 3 years of their diagnosis, and then came up with a model. Whereas our model was like bottom up, where as has been seen with various staging systems, including staging systems for myeloma, where you look at the overall survival, you follow those patients, and the ones that that are low risk would essentially have a very good 10-year overall survival rate, given that this disease is very indolent. On the other hand, with the revised IPSS scoring system, it segregated the population that was at so-called really high risk, very, very high risk. So the two models are somewhat complementary in my mind, in the sense that the modified staging system actually segregates patients very nicely into 4 risk groups, whereas the revised ISS actually segregates patients into low risk and high risk, but all the intermediate risk patients are actually we couldn't validate these model, and those curves were overlapping and intertwined. So that was precisely what led us to actually derive the staging system, because we couldn't validate the revised IPSS based on those parameters. So in effect, the revised IPSS model could isolate the patients who were at really high risk of dying, whereas this model could identify patients in all 4 categories, but the so-called ultra high risk was not necessarily captured by this model or isolated by our model, because the ultra high risk were the ones that also had elevated beta-2 microglobulin. And once we incorporated beta-2 microglobulin, then the entire staging system, including the intermediate and low intermediate, those stagings, those curves would start to move up. So essentially, our model would behave very similar to the revised IPSS, because the difference is actually very tiny. And so our model does not incorporate beta-2 microglobulin. The revised IPSS does. In our model, as Dr. Balasubramaniam said, that we looked at the MYD88 mutation status. Revised IPSS did not take that into account. So there are pros and cons of using each of these models. But I would say because the revised IPSS has not been validated, including in their own validation cohort, there were issues. We generally do not recommend using that. But if you want to frankly find out the patients who are really, really poor risk, I would think their model is better. And I say that because within our model, if we look at the MSS high cohort and add beta-2 microglobulin to it, it would divide those patients, stratify those patients into sort of 3A, 3B, or rather stage 4 high risk A, high risk B category. But then the high risk A category sort of has similar outcome to the intermediate risk. So the model falls apart because the beta-2 microglobulin in our model was only a prognostic parameter in the univariate analysis and not in the multivariate. So our model is built on a solid footing. But what we are going to do is ultimately define a very high-risk patient population, because we are talking about years and years. Waldenstrom patients could live more than a decade, and with newer therapies, 15 to 17 years. That would be the median overall survival. So what we would actually be proposing is a group of really high risk. So we look at high risk and we leave all of the others in another bucket. And this is something that is going to come out of the recent workshop, the IWWM workshop that took place last week, that we will take into account patients who are really high risk and also attempt to incorporate other high risk features which our staging system lacked. For instance, we would try to look at CXCR4 mutation. The problem is there are very few centers that do this testing, and that is because it's a complex testing. NGS is required because there are about 30 to 35 different types of CXCR4 mutations. So you cannot have a PCR against a specific site, unlike MYD88. So it's a difficult to perform test. Besides its validity, or I should say utilization, outside of the BTK inhibitor use is also somewhat, the data are also somewhat limited. So if you're using bendamustine rituximab, while our study has shown that those patients with CXCR4 mutation don't do as well with BR either, and it's the mutation confers resistance. I believe our study actually has to be validated by other cohorts, external cohorts, before it can be universally adopted. Although ours was a multi-center international study that has not been published yet, it is in the process of being written up. So overall, the bottom line is, this staging system appears to be valid. Obviously, it has to be utilized by clinical trials for risk stratification. But ultimately, the clinical trials also have to look at the high-risk patients, the true high-risk patients, for which I think we should be using, also incorporating beta-2 microglobulin, as was also shown by our cohort, but we did not quite put it in the staging system, because that would have affected all the intermediate risk groups. So that's where we stand. Additionally, we don't have data on deletion 17p and TP53 mutation. Frankly, at the time of the diagnosis, with this being a low proliferative lymphoproliferative disorder, deletion 17p or TP53 mutation is seen in up to 5% of patients. But at the time of relapse, that increases to up to 15 to 25% of patients. So that would be a recommendation as well going forward to check for these mutations. And ultimately, the questions that we have to, the way we have to move the field forward is to build upon these staging systems and consider incorporating all these other molecular parameters to ultimately further risk stratify and accurately assess the prognosis of the patients. What was also important, I just want to highlight one thing, is that the Sankey plot where you showed that the patients moved from one staging category to another, that was for the IPSS-WM, not the revised IPSS-WM. So that was from the original cohort versus the new staging cohort. So in fact, in the current era, many of those high-risk patients were downstaged to low risk category or low intermediate or intermediate risk category. A very easy to use staging system. We all do beta-2 microglobulin. We all check LDH at the time of diagnosis. And so it's very easy to apply to our patients.
Thank you, Prashant. That was nice. But I have a question.
Dr. Prantar, can we allow Ramesh to complete its 1-2 more slides, whatever, then we can
The
discuss.
conclusion slides? Yeah. We actually heard it, but did not see it.
Okay,
Anyway,
Dr. Prashant has given his, observations and background to the, study, but let Dr. Ramesh complete
Ramesh,
it.
please.
Then we can, have your comments. We'll take 2-3 minutes more. No problem. Absolutely.
Please, Ramesh.
Thank you, sir. Sorry, my internet connection got disconnected. Thank you. Just a
You
minute.
have to sort whatever is the last final 1-2 slides.
Yeah.
Then we can proceed.
So this sir has mentioned like the limitations retrospective study in CXCR4 mutation being because of the incorporating it into the system is challenging because of the cost and the complexity of the test, and the only the patients BTK inhibitors after the shorter follow have been incorporated in the trial. So it leads a larger prospective study with the BTK inhibitors, and by applying this modified staging system. So to conclude, this is a simple externally validated system for depending on only just 3 parameters like age, serum albumin, and LDH. It has a better discriminative ability, especially the intermediate risk groups, with using the limited variables and using only with the 4 risk groups. So with this provides a platform for future refinements by incorporating other genetic and molecular mutations like deletion 6q and deletion 16p and mutations in TERT, CXCR4 and TP53. That's all. Thank you.
Dr. Prantar, all yours. You can.
Yeah. Nothing is mine. Don't worry. I only want to say, especially to the youngsters who are watching, that this is the importance of keeping the data and following up the patient, right? Because in future, even, as we use more machine learning and other tools, there will be a number of things which our brains are not seeing at present. And it being a rare and an indolent disease, you have to follow them up, because my problem with such staging system is still that in the real world, when a patient, especially a young person, sits in front of me and I tell them, okay, you are in this group and this is this, it still is only statistics. I do not know whether it actually tells the story of this patient. So thanks to the Mayo Group for doing such a study, and I would always thank them for keeping all this data so they can go back, look at other things and all. But I think we all have to join in this to understand the disease is better because it is heterogeneous. There's no doubt about it. And I think one important thing will come up through this efforts is that what to use in a particular person. Like he mentioned about CXCR4, maybe because we have access to bendamustine rituximab, we have access to bortezomib-based regimes, and we have the BTK inhibitors, and that too we have generics. But is there a group who will benefit more from a particular class of agents? Because whatever we use, we will use it. If we use it for a limited time, again the disease will come back. And if we are using it lifelong, such as BTK inhibitors, we have to see that the toxicity is also less and the patient enjoys the life. So this is what I have to say. I think Prashant can give the concluding comments.
Sure. No,
Thank you. Dr. Prashant, sorry, I forgot to introduce you. In the faculty group, everybody knows you, but at least the delegates, they need to know Dr. Prashant Kapoor is from Mayo Clinic, Rochester, and he is our international faculty today. By the time I was talking, you had not joined in, so sorry for that. And your observations were so great and nice. Just one, query from my side. Is this new, staging is going to help us to treat our patient with the newer agents, and with the newer molecular markers which are going to come in, days to come, like you mentioned about TP53, 17p deletion, all those things are going to aid in the staging, and it is going to give us a kind of prognostic model in this?
So the short answer is we are not recommending changing our treatment on the basis of this staging system. And as Dr. Chakrabarti astutely observed, these platforms are not going to tell us about an individual patient. So when we do speak, and this is frankly applicable to any of those staging systems, including the myeloma staging systems, which are going to just put patients in different buckets. But within that bucket also, there's a median overall survival, and some patients would live longer, some would live shorter. The problem with all these staging systems is that you need a long follow-up, and by the time the data comes out, the patient that you're seeing who's in front of you is already having somewhat better prognosis than what the staging system is going to show. And especially for a chronic and incurable malignancy, the longer the patients are able to remain in remission, overall their chances of survival improves, because during that period, it's not just that the disease is under control, but there's a lot of progress that is being made contemporaneously in the field. And so if their disease, somebody who was seen in 1995 and lived for 5 years, or had a disease that was in control for 5 years, did not necessarily have access to bortezomib, did not have access definitely to BTK inhibitors, probably not to rituximab, because the use of rituximab in Waldenstrom, frankly, didn't quite pan out until after the year 2000. So what I'm trying to say is the longer they are able to have their disease in remission, the better their chances that they would have access to newer drugs. And that in turn would improve their overall survival. Having said that, at the most recent workshop, one of the groups actually was still unable to, this is the Greek group, still unable to show a survival improvement following introduction of BTK inhibitors. And I personally believe that's because of the indolent nature of this disease. All we need to do is just follow these patients up for another 5 years, and we will start seeing the differences in those curves. So I think the staging system is applicable to patients who have active disease, but the treatment decisions should not necessarily be based at the moment. This is something that's aspirational, and over time, hopefully, we'll be able to figure out which treatments are better for certain subsets.
I think Dr. Sumit has got some question.
Yes, sir. Am I audible?
Yes.
Yes.
Yes. So we have now 3 scoring systems, all of which predicting survival in some way or the other. Is there any scoring system to tell us to predict the risk of transformation in a low-grade indolent lymphoma like Waldenstrom?
Yes, there is actually a scoring system that it doesn't tell the risk of transformation, but it does tell you whether how the patients would do once they have transformed. What does tell us about the risk of transformation is whether they have MYD88 mutation or not. We don't have a formal staging system predicting the risk of progression or transformation specifically, but if they have MYD88 wild type status, those patients are I think 7.5-fold higher at a higher risk of transforming compared to those who have MYD88 mutation. But even with that substantial increase in transformation or risk of transformation, the overall absolute numbers are very low, and the chances of transformation is less than 5% over the course of the disease.
One more thing is, do you believe that deletion 6q, which is one of the most common cytogenetic abnormalities, does its presence as such in a low-grade indolent disorder portend any poor prognosis to these patients?
So there is a lot of conflicting data with the deletion 6q. There are groups that have shown that it is actually prognostic, and then there are groups that have shown that it isn't prognostic. Suffice it to say that in the new consensus criteria that we will see next year regarding this high-risk WM, this 6q, at least at the moment that I know, will not be included as a high-risk feature. And we routinely do not test for 6q, deletion 6q.
Okay, thank you very much. Thank you very much, Dr. Prashant, for enlightening us. Now the next is Eagle Eye competition. Dr. Sumit, you can start.
Is my screen visible, sir?
Yes.
Okay, thank you very much. So this time's Eagle Eye competition article for October 2024 was based on this article, a randomized phase 3 trial of zanubrutinib versus ibrutinib in symptomatic Waldenstrom macroglobulinemia, the ASPEN study. So for those who are new to the process of Eagle Eye competition, the process is basically a recently published article has been chosen, and a commentary of 175 words is asked for before a due date and deadline to us. Anybody is interested can send, and it is reviewed by a set of blinded reviewers. The intention is that the latest articles of plasma cell dysplasia are read. Students and junior faculty in India learn the art of physical appraisal and the art of scanning an article. This will help getting more light to editors from our country and an opportunity to present in front of a very good audience. So the rules are that following variables should be analyzed, which should include a summary, the title, the abstract representation, author's core assumptions. Most important is critical word limit, errors in the author's interpretations and fact. Some ideas may be over or underemphasized, approaches, statistical methods, and finally we arrive to a final score depending on the references. Most important rules are sticking to the word limit, being succinct, and still can be the critical analysis, and concentrate on the methodology as well as statistics, which we all as such tend to ignore at times. So I'm grateful first of all to my reviewers, Dr. Pranjal Chakraborty sir and Dr. Satyaranjan Das sir. I'm very grateful to both of them also because they happen to be both of them and DM exit examiners, and it was not so good exam, but a very good examiner as such. Thank you. So a special mention for Dr. Jeet Gala, who is a senior resident in hematology at OZPJ Lucknow. His commentary was very good, but he crossed his word limit by a significant amount. So while the content was good, you should learn to stick to your word limit in order to get some prizes in the future. And the winner for today is the second time in a row consecutively, Dr. Vallish Chenoy. He is a DM resident in medical oncology at TMH Parel and Actrac Mumbai. So congratulations for a second honor trot consecutive, Dr. Vallish Chenoy. And I hereby request Priyanshi Neera to play the recorded commentary.
Good evening, everyone. I'm Dr. Vallish Chennai. Thank you for giving me this opportunity to present this journal scan on a randomized phase 3 trial of zanubrutinib versus ibrutinib in symptomatic Waldenstrom's macroglobulinemia, the ASPEN study. Coming to the introduction, it is a B-cell malignancy characterized by IgM secreting lymphoplasmacytic cells. The MYD88 mutations are present in more than 90% and CXCR4 in 30 to 35%. Coming to the BTK inhibitors, the first generation inhibitor ibrutinib showed a MMR or major response rate of 78% in relapsed refractory and 83% in treatment naive. The common toxicity were atrial fibrillation and hypertension, whereas zanubrutinib, a new generation BTK inhibitor, showed a major response rate of 82% with less off-target effects and lower toxicity rate. Coming to the methods, it was a randomized open label comparing ibrutinib versus zanubrutinib in patients requiring treatment for Waldenstrom's macroglobulinemia. In the cohort 1, they had taken patients with the MYD88 mutation, randomized 1:1 to receive ibrutinib 420 mg daily or zanubrutinib 160 mg twice daily. In the cohort 2, they had taken patients with the MYD88 wild type or undetermined status who had received zanubrutinib, and this was a non-randomized cohort. And the stratification was by WIM-like mutations and prior therapies. The endpoints of the study were primary endpoint VGPR and CR rate, and secondary endpoint was MRR, duration of response, progression-free survival, and safety. The eligibility of this study was that relapsed refractory Waldenstrom's macroglobulinemia patients after one or more than one prior therapy or treatment naive unsuitable for standard immunochemotherapy. Key exclusion were prior BTK inhibitor exposure, CNS involvement, significant cardiovascular disease, and the outcomes were VGPR CR and safety assessed by CTCA. So this is the same, showing that 250 patients were taken, out of which 201 were randomized 1:1 to zanubrutinib, ibrutinib, and then were treated accordingly. Coming to the statistical analysis, the primary analysis was conducted 12 months after the last relapsed refractory patient was randomized. CR VGPR superiority was tested using the Cochrane-Mantel-Hansel test, and superiority was declared if PE value was less than 0.05, and non-inferiority in MRR was declared if 95% confidence interval limit excluded 25% margin. So coming to the results, in patient characteristics, 201 patients were enrolled, 164 relapsed refractory and 37 treatment naive between January 2017 and July 2018. The most common indication was therapy was fatigue, anemia, B symptoms, hyperviscosity, and peripheral neuropathy. The treatment was balanced for key characteristics, but zanubrutinib patients were more than 75 years of age and anemic. CXCR4 WIM mutation was present in 11% of the zanubrutinib arm and 8% of the ibrutinib arm. This is the same, which explains that table. And coming to the responses, no CR was achieved in either arm. VGPR rate was higher in the zanubrutinib compared to the ibrutinib arm. MRR was comparable between the both arms, and the type 2 VGPR was less in the zanubrutinib arm, which was 5.6 months versus 22.1 months in the ibrutinib arm, and the time to MRR was 2.8 months in the both groups. But when CXCR4 WIM mutations were taken, it was 6.6 months in the ibrutinib versus 3.1 in the zanubrutinib arm. This is the Kaplan-Meier graph showing that the duration of CR or VGPR probability is more with zanubrutinib compared to ibrutinib. Coming to the PFS and OS, median PFS was not reached in either arms, and the 18-month event-free survival was comparable, and the OS rate at 18 months was 97% for zanubrutinib and 93% for ibrutinib. Coming to the IgM and hemoglobin levels, it was almost similar trend, with the hemoglobin showing plateauing after cycle 6. Coming to the bone marrow and extracellular disease reduction, zanubrutinib shows 69% bone marrow disease reduction, whereas 73% with respect to ibrutinib, and the lymph node or spleen reduction was similar between the two arms. And coming to the safety and patient outcomes, the median treatment duration was 18.7 months in both arms, and the common adverse effects were neutropenia in zanubrutinib and peripheral edema with respect to ibrutinib, and the grade 3 or more than 3 side effects was seen in 58% of the patients in zanubrutinib arm and 60% of the patients in ibrutinib arm. Infections were comparable with pneumonia higher in the ibrutinib arm, atrial fibrillation was higher in the ibrutinib arm, and the zanubrutinib had a better quality of life. In the subgroup analysis, it showed that zanubrutinib showed a consistently higher VGPR rate, especially in the patients in treatment naive patients as well as in patients less than 65 years and more than 65 years of age. Better reduction of the extramedullary disease, and it showed a better VGPR rate, especially in European patients with the baseline IgM level of more than 40 gram per liter, in baseline hemoglobin more than 11, and baseline beta 2 microglobulin more than 3. And this is the same forest plot which I have explained. And coming to the side effect profile, zanubrutinib have a lower incidence of atrial fibrillation, hypertension, and bleeding events and diarrhea, whereas the grade 3 neutropenia was more in zanubrutinib, but this did not lead to higher infection rates. This is the Kaplan-Meier graph explaining the same. And coming to the discussion, zanubrutinib showed a higher VGPR rate compared to ibrutinib, a higher IgM reduction, a good safety profile due to fewer off-target side effects, and a better quality of life with respect to fatigue and physical functioning. It had a greater selectivity and also a more sustained ITM reduction. The unanticipated outcomes of this study was that only 9% of the patient had CXCR4 WIM mutations compared to the historical rates of 30 to 35%, and this was due to the initial usage of Sanger sequencing, which led to the underestimation. But the post-hoc analysis changed these findings, where the NGS showed that 28% of the patients had CXCR4 compared to the 9% detected with Sanger sequencing. Also, VGPR by CXCR was status when it was taken. NGS data showed a higher VGPR rate for zanubrutinib, even in patients with wild type and in mutated CXCR4. Important observations seen in this trial was that zanubrutinib have a lower incidence of diarrhea due to less inhibition of the EGFR. A grade 3 neutropenia was more common, but it did not attribute to higher rates of infection, and a longer treatment may enhance the response, as seen in a phase 2 trial, where after 36 months, a 51% VGPR CR rate was seen. Thank you.
Nirav, now you can share the slides from your end. Make it on full screen mode. Right. So thank you, Dr. Valish, for the nice commentary. Now it's time for the quiz questions. Next slide. So this is the myeloma quiz today. Next. We will have 5 questions, 2 on the basis of Journal Club, 2 on the basis of Journal Scan article which Dr. Valish presented, and 1 will be a trivia question. The fastest finger first will get an attractive prize as well as a certificate. Next. So question 1, which of the following is incorrect regarding the Aspen study, which was a Journal Scan article? None of the patients in either arm achieved the CR. The 18-month PFS was similar in both the arms. Only patients with immediate L to 65P were included. VGPR rates were not significantly higher for zanubrutinib, while time to VGPR was similar in newly diagnosed patients with both the drugs. And samples of the 150 patients were their superiority hypothesis of zanubrutinib over ibrutinib. You have to choose the incorrect statement. Next. The second question is, which of the following again is incorrect regarding the Aspen study? A, all grade diarrhea, muscle spasms, peripheral edema, and bleeding were higher with ibrutinib than zanubrutinib. More than equal to grade 3 AF and pneumonia was higher with ibrutinib. Neutropenia rates were higher with zanubrutinib, but there were no difference in grade 3 infections in both the arms. Cumulative incidence of hypertension and atrial fibrillation decreased with time for the ibrutinib arm. And last, higher proportion of patients with ibrutinib required dose reduction for adverse events. Each of these following parameters of the IPSS-WM was found to be significant on univariate, but not on multivariate analysis of modified staging system for balance storm. A, beta 2 microglobulin more than 3. B, anemia. C, platelet less than 1 lakh. And D, IgA more than 7 grams. This must be very simple because it was discussed extensively even during the discussion part. Next. Actually, following is false regarding modified staging system for Waldenstrom. A rates of Richter's transformation progression to amyloid was similar across all these subgroups. The presence of immediate mutation favored a significantly better survival. C, 1/3 patients died because of non-Waldenstrom related causes. The correlation with cytogenetic abnormalities like deletion 6q was not studied in this study. You have to choose the false statement. And coming to the last question, a 60-year-old man with past history of Waldenstrom's presented with confusion, progressive cognitive decline, slurred speech, and ataxia, has an N band of 1.5 grams and an IgM of 2.2. What is the likely diagnosis? You have an MRI with some arrows showing something, an immunofixation, and a CSF flow cytometry. It's either A, Tempe syndrome, B, hyperviscosity, C, IgM flare, D, Bing-Neal syndrome, or E, Canomat syndrome. So now coming to the answers, we'll start with answer 1. Next slide. So the following is incorrect regarding the Aspen study. The correct answer here, which was incorrect, was yes, VGPR rates were non-significantly higher for zanubrutinib, but the time to VGPR was also earlier for zanubrutinib versus ibrutinib, especially in newly diagnosed patients. This statement is incorrect, whereas all A, B, C, and R are correct. Next answer. So the following is yes, all grade diarrhea, muscle spasms, edema, bleeding were higher with ibrutinib. As we would know, more atrial fibrillation and pneumonia with ibrutinib. Interestingly, the pneumonia was much higher with ibrutinib than the zanubrutinib. Neutropenia rates were higher with zanubrutinib, and you would expect that infections would be high, but there was no difference in the grade 3 infections in both the arms. Instead, pneumonia was higher with ibrutinib. The atrial fibrillation and hypertension cumulative incidence did increase over time for the ibrutinib, which means that it's a time-dependent event which accumulates over a period of time, and it doesn't come down even when the patient is otherwise tolerating it well. And the last option was correct. Higher proportion of events in the ibrutinib required dose reduction. Yes, because there were more adverse events. The correct answer here is option B. Next. As discussed extensively, beta-2 microglobulin was found to be significant univariate, but not on multivariate with modified staging system for Waldenstrom. So the correct answer here is beta-2 microglobulin, option A. Next. Each of the following statement is false regarding the modified staging system. Variate was done in only a minority of patients, and only 17% patients actually received ibrutinib or BTK inhibitors. So probably that may be one of the reasons why it did not impact survival in this cohort of patients. So the correct answer here is B. Presence of variate favored a significantly better survival, wherein actually did not. A, rate of Richter's transformation and amyloid was similar. Yes. 37% patients actually died because of non-Waldenstrom related causes. Just goes to show that an indolent disease can have mortality because of causes which are unrelated to the underlying malignancy. And D, as again discussed, there was no correlation with cytogenetic abnormalities, probably because it's an indolent disease where you don't get much patients with cytogenetic abnormalities. And the last question. This was in fact Bing-Neal syndrome. It's a rare complication or an event in the life history of a patient with Waldenstrom macroglobulinemia. In slide 1, the MRI, you can see the leptomeningeal enhancement, immunofixation showing the IgM kappa restriction corresponding to the alpha-fluorescent band in the first lane, and the CSF is showing morphologically as well as immunophenotypically cells which are consistent with lymphoplasmacytic lymphoma. So this is a CNS event of Waldenstrom called as Binnenweiss syndrome, which has two variants, either electromeningeal or a parenchymal form. A closed option was Canomide, but that basically has ophthalmoplegia and a lot of bulbar weakness, which was not the case here. The IgM and the M band both were quite low. So unlikely there it would be hyperviscosity for option B. IgM flare also unlikely because this patient has not been treated with rituximab, and this is not the way an IgM flare presents, whereas TEMPI is a completely unrelated entity. So next slide. So before we announce who's the winner, we would like to make an important announcement regarding the Indian Myeloma Congress. Next slide. So as we would all know, Indian Myeloma Congress 2025 is scheduled from 10th to 12th of January 2025 at the prestigious Tata Medical Center, Kolkata. The organizing chairpersons for the same are Dr. Reena Nair Madam, Dr. Deepak Mishra Sir, and the organizing secretary, Dr. Jeevan Kumar Sir, and Dr. The last date for abstract submission is 30th November 2024. So please remember the deadlines and send your abstracts as much as possible. Next. So do we have the winner? Neerav Muthushi?
Sir, the winner is Sandhya Uma Maheshwaran from Chidambaram Diagnostic.
Chidambaram Diagnostic. And the name is?
Sandhya Uma Maheshwaran.
Sandhya. So congratulations, Sandhya. We will revert back to you regarding your prizes. Thank you. Over to Dr. Satyaranjan Dasa for the closing remarks. Either we can stop here. Dasa?
Okay. Sorry, I was on mute. Thank you very much. I want to thank Dr. Prashant for, really giving us the background to the study. And of course, Dr. Chakravarti and Dr. Ramesh. There was a good discussion and excellent presentation by Dr. Ramesh. Thank you very much. I think we're just 6 minutes past 6:30. It's time to close now. Uday, have you got any announcement or anything?
No, sir. Thank you, sir. So Sumit has already announced for everybody for that, sir.
Yeah. Thank you. Thank you very much. Thank you, Dr. Prashant, again.
Thank you. Great.
Thank you. Bye-bye.
Bye.